Thank you for tuning in to this talk about palliative care for Canadians with heart failure. My name is Laura Runcie, and I want to start by saying how excited I am to finally be giving this presentation. My interest in the relationship between heart failure and palliative care began as a personal soapbox topic after noticing the cyclical trend of heart failure CCU admissions, and not just a missed opportunity, but opportunity avoidance to empower individuals with informed decision making in relation to disease progression and management. We are in the business of saving lives, and we're good at it, but at what cost? And who decides if the cost is worth paying? How do we balance quantity and quality of life, and who decides which is more valuable? These questions haunt me, and as such, I prepared a related presentation in 2017 to be presented at the CCCN Spring Conference, however, was derailed by a personal situation. So I did the next logical thing, opportunistically utilized the topic for a paper written during my master's. The following year, I prepared an abstract for presentation for the 2020 CCCN Spring Conference. Then COVID hit. It's like the universe has been as reluctant to hear about the role of palliative care in heart failure as cardiologists are. But at last, with a little more research and no less passion, here we are. The goal of this presentation is not to inundate you with new, groundbreaking statistics or treatments, but to challenge the way we approach palliative care in the context of heart failure. We'll start with a quick review of heart failure, palliative care, and the CCS guidelines specific to this topic. Afterwards, we'll delve into some of the barriers to providing adequate palliative care to Canadians with heart failure, and finish with a few recommendations to enhance the provision of more inclusive and holistic health care. I want to challenge you to evaluate the role you currently play in your patient's heart failure journey and the role you'd like to play in the future. So let's begin. In 2016, the Heart and Stroke Foundation released a report titled The Burden of Heart Failure and defined it as a growing epidemic. At the time, they cited that more than 500,000 Canadians had heart failure and that each year 50,000 more were diagnosed. Statistically, of the 50,000 that were diagnosed the year that report was published, more than half have since died. Heart failure is a big deal. Its impact is far-reaching, and it isn't going away. So what do we need to know and do to help alleviate the burden? To start, what is it? Heart failure is a chronic, progressive, incurable disease with alternating periods of stability and symptom exacerbation. It occurs when the heart's muscle is unable to pump enough blood to meet the body's demand. And that's basically all you need to know for this presentation. We're not going to focus on the pathophysiology of heart failure, whether ejection fraction is preserved or reduced, or even on treatment details. Instead, we need to understand that as the disease progresses, symptom burden increases, and during episodes of symptom crisis, individuals living with heart failure risk frequent hospital admissions, which is directly correlated to increased mortality. Aside from an ultimate conclusion, the disease trajectory of heart failure is challenging to predict. The hallmark symptoms include shortness of breath, fatigue, weight gain or edema, and orthopnea, but there are so many more. People living with heart failure may also experience anorexia, anxiety and fear, constipation, coughing, depression, hopelessness, and suicidal ideation, cardiac arrhythmias, insomnia, liver congestion, renal dysfunction, muscle weakness, nausea, pain, palpitation, confusions, and reduced functional capacity. Heart failure is a very personal disease, and as such, individuals may experience some but not all of these symptoms, and at varying degrees throughout their course of illness. This variability contributes to the challenges of managing heart failure and the inconsistencies of care delivery. Heart failure treatment is not curative, and the goal of care is to increase quantity and quality of life alike. Both inpatient and outpatient management is focused on disease progression delay and symptom avoidance or relief. In effort to prolong life, ideally while maintaining acceptable quality of life, patients may benefit from a variety of treatments, including lifestyle modifications such as diet, exercise, and smoking cessation, counseling or therapy, medications, implantable devices, and electrophysiology procedures, including pacemakers, ICDs, CRT, ablation, and VADs. In some circumstances, heart transplant may even be considered. And of course, when we've run out of options, hospice care. Now, I'd like to distinguish that palliative care differs from hospice care, which is specifically intended for individuals with a 6-month or less prognosis. I'd also like to remind each of us that the integration of palliative care is in no way an indicator of failing our patients, nor does it mandate the withdrawal or withholding of life-prolonging care. Palliative care is more of a style of care delivery that we have a responsibility to provide and that complements ongoing and even life-prolonging treatment. It might be helpful to think of palliative care in a two-tiered approach. Primary palliative care being provided on an ongoing basis by primary caregivers, and secondary palliative care would include specialist consultation and may not be required at every step along the disease trajectory. In 2014, the World Health Assembly made a call for palliative care integration into primary health care, stating that it is an ethical responsibility of health systems and that it is an ethical duty of healthcare professionals to alleviate pain and suffering, irrespective of whether the disease or condition can be cured. While palliative care has been more widely incorporated and researched within the oncology realm, its use within cardiology is either underutilized, under-reviewed, or both. This is devastating because specifically in the context of heart failure, we know there isn't a cure, and we know that both the individual with heart failure and their caregivers are experiencing pain and suffering. Furthermore, incorporation of palliative care is recommended in the management of heart failure by the Canadian Cardiovascular Society. They describe palliative care as a patient-family-centered approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. It is applicable early as well as late in the course of illness in conjunction with other therapies that are intended to prolong life. The CCS definition of palliative care sounds like a lovely philosophy of care, but what does it entail from a practical perspective? The first question to ask is who is involved in the delivery of palliative care. Ideally, an individual with heart failure would have access to a multidisciplinary care team, including non-medical professionals, such as themselves, family and friends, and pastoral care, but also obviously the team would require physicians, both specialists, such as cardiologists, internists, psychologists, and palliative care specialists, and general practitioners. Nurses also play a key role in this team, and for now I mean anyone who delivers nursing care, from nurse practitioners to registered nurses, licensed practical nurses, and care aides. Finally, the team would not be complete without allied health professionals. Physio, occupational, speech, and respiratory therapists, registered dietitians, pharmacists, and social workers, to name a few, may be required to optimize quality and quantity of life both on an ongoing basis as well as in a consultative role. Secondly, where and when should palliative care be addressed and/or delivered? This is challenging as there is no simple answer. The CCS definition of palliative care indicates it could be appropriate both early and late in the course of illness and is individually based, thus requiring frequent reassessment. Individuals may need varying levels of support throughout their course of illness, while others may not want or need anything until the very end. Regular discussion should be occurring during times of stability in a safe environment with trusted care providers. This could be during patient visits, home visits, in community specialty clinics, through telehealth, and every other means of healthcare contact a person has. Ideally, a crisis situation, such as being admitted to the CCU with symptom overload or pre-code, is not the time to introduce palliative care or end-of-life planning. Now, what exactly does palliative care entail? The two definitions of palliative care already cited broadly state that it prevents and relieves suffering of all varieties for both patients and family or caregivers, while improving quality of life and without withholding life-prolonging or sustaining treatments. It includes communicating with patients and the multidisciplinary team to deliver care that is in alignment with advanced care directives or plans and goals devised by well-informed patients. In order to deliver effective palliative care for patients with heart failure, patient education must be forefront. Understanding disease progression, treatments, and prognosis enables patients to participate in shared decision-making. Integrating palliative care into heart failure management allows the care team to hope for the best while planning for the worst. And finally, why should we deliver palliative care to people living with heart failure? To start, because people want it. Perhaps not by its name, but its practice. Not only do people want to live longer, but they want to live more comfortably. Generally, They also want to be more informed, understanding their disease progression and treatment options. A palliative care style of healthcare enables this. Secondly, it is necessary. 90% of annual Canadian deaths are due to chronic illness, including heart failure. We cannot change the fact that everyone, with or without heart failure, will eventually die, but we can impact their experience with dying. 75% of Canadians want to die at home, yet 60% die in hospital. So clearly, there are missed opportunities to improve dying. But remember, palliative care isn't only focused on dying well, it also optimizes living well. The CCS acknowledges that palliative care in advanced chronic illness can improve patient and caregiver outcomes, reduce health service utilization, including hospitalization and length of stay, and increase chances of dying at home. Inclusion of palliative care in heart failure empowers individuals to create advanced care plans on their own terms, enabling effective continuity and delivery of care in compliance with patients' own wishes and goals. It improves comfort, spiritual well-being, symptom relief, self-management skills, and thus independence, while decreasing caregiver burnout and pain. Surprisingly to some, palliative care is even associated with prolonging life expectancy. Most importantly, palliative care improves quality of life. The CCS first released their heart failure management guidelines in 2002. However, palliative care was not included until 2006. Physicians were initially advised to consult a palliative care specialist when a patient was deemed near end of life, and the goals of care had shifted from quantity to quality of life. This introduction of palliative care to heart failure management was unfortunately ambiguous and reinforced stigma that palliative care is only for those imminently dying and is not able to coexist with active, life-prolonging treatment. Over the next 10 years, the palliative care recommendations slowly evolved to include the early involvement of a multidisciplinary team, regardless of being considered at the immediate end of life or not, with a focus on symptom management. They also released a formal definition and emphasized the incorporation of palliative care based on patient-specific needs and as standard advanced heart failure management. In 2016, the Heart Failure Guideline Update focused on implementing recommendations into practice. Practitioners were advised to have early and frank discussions with patients and their families about end-of-life preferences and provide palliative care in appropriate patients. This practice was further reinforced in 2017 by encouraging palliative care referral based on regular, thorough assessment of needs and symptoms, with an emphasis on symptom and psychosocial burden rather than individual estimates of remaining life expectancy. Finally, the most recent CCS heart failure-related update, including modified palliative care recommendations, is the 2021 Heart Failure Pocket Guide, in which palliative care referral is still emphasized in advanced heart failure, and more specific criteria is provided to help practitioners know when to call a friend. You'll also note a small caveat remains to incorporate patient preference in considering palliative care. These guidelines should be quite helpful. They come from a trusted source and indicate that palliative care is beneficial to heart failure patients as needed. Unfortunately, we still see a gross underutilization of palliative care in conjunction with heart failure. But why? Barriers to equitable access to palliative care can largely be divided into two categories: people and context. While people are necessary for the delivery of palliative care, personnel can also prove a hindrance. With so many involved in the multidisciplinary team, it can be challenging to align treatment modalities and goals. The larger the team, the more complicated communication becomes. Also, if an identifiable team lead is lacking, patients and their values are likely to fall through the cracks. On the flip side, not having access to enough or the right personnel can also hinder a person's access to palliative care. Beyond general healthcare worker shortages, there are simply not enough people with palliative care specific training to properly service the nation's heart failure population. And while it is recommended for palliative care to be delivered by primary care providers, the literature indicates that a majority feel ill-equipped and uncomfortable to do so, with a lack of palliative care-specific education and training frequently being cited. Patients also feel undereducated to participate in informed decision-making, usually trusting their primary care providers to know what is best. This issue is further compounded by a lack of effective communication opportunities between care providers and patients. The process of patient education, shared decision-making, and advanced care planning is time-consuming, emotionally exhausting, and intimidating. Short, irregular appointments are not conducive to this. To further inhibit the access of palliative care, each person comes with their own preconceived notions, which are likely clouded by misconceptions and fear. Having heart failure can be terrifying. Both understanding and not understanding the disease progression is daunting. Concerns regarding care being withheld are prevalent. A sense of failing as a care provider exists. The fear of death is real. The fear of telling someone they will die is real. There are a lot of reasons why both people living with heart failure and their care providers are reluctant to discuss the role of palliative care in heart failure, and thus limiting its use. The stigma that exists surrounding palliative care, that it is only for those imminently dying, that it will result in care being withheld or withdrawn, or that it is only intended for people with cancer, has a long-standing history that will take years to overcome. It is not particularly helped by a lack of research in palliative care in a non-oncology context, by vague and broad recommendations, or current education curriculums. The integration of palliative care is also not facilitated by the unpredictable course of illness associated with heart failure. Patients and healthcare providers alike find deceptive hope in the cyclical disease process. Patients are generally expected to rally from episodes of symptom exacerbation. This makes prognostication very challenging, and current tools to aid this process are reportedly cumbersome and inaccurate. Demographically, younger individuals and racial minorities receive less palliative care than their older white counterparts. Geographically, living in rural areas also inhibits your access to palliative care resources. This is a downfall of Canada's healthcare system and its financial model. It is impossible for the current system to enable individuals living anywhere in Labrador to have the same access to heart failure or palliative care resources as someone living in Toronto or Vancouver. Even if a person lives in an area with excellent resources, the healthcare system itself can be challenging to navigate and does not lend itself well to the time-consuming appointments necessary to achieve the goals of palliative care integration into heart failure management. So how do we work within a system that is pitted against equitable palliative care for Canadians with heart failure? Well, it goes back to the greatest barrier of people becoming the greatest facilitators and advocates. This is the how part of the presentation. I've surmised the recommendations found in the literature into 5 easy T's. The first is to train. If the delivery of palliative care to heart failure patients is an ethical responsibility, then we have a professional responsibility to ensure that we are equipped to do so. To overcome the lack of training, education, and comfort described earlier, we have to be proactive, to seek training when needed, and to offer it when able. Now, we don't all have to become specialists, but through conferences, courses, engaging with multidisciplinary team members, and even advocating for curriculum updates, we can improve not only our own training, but that of those around us. The more we know, and the more regularly we engage in palliative care, the more comfortable we will become in our roles in primary palliative care delivery for people with heart failure. The second is to teach, specifically to teach our patients. Healthcare professionals have a responsibility to teach their patients about disease progression, symptom recognition and management, treatment options, and prognosis. As mentioned, this is challenging, but its value cannot be underestimated. When patients are properly equipped, they are better able to make informed decisions, participate in shared decision-making, and be active participants in their own health maintenance. Thankfully, there are a number of standardized, low health literacy level resources that can be used to facilitate consistent patient teaching. Next, we have the team. In order to successfully integrate palliative care into heart failure management, all members of the multidisciplinary team should be welcomed to participate in shared decision-making and to share the burden load of heart failure. Each member comes with different strengths and as such should be utilized as necessary. In order for the team to be effective, the patient needs a point person who can advocate for them, assist in navigating the system, and coordinate personnel involved. Ideally, this would be their primary caregiver, but may not be in all circumstances. Regardless of who heads the team, effective communication is vital. As such, the fourth T is talk. Healthcare providers need to talk to their patients to teach them and to learn their values and preferences, to better recognize symptoms, and to create advanced care plans. Care providers should communicate openly and honestly with their patients, ideally delivering small amounts of information at a time while assessing patient cues and comprehension. Patient assessments throughout their journey with heart failure should be continuously linked with updated management plans, which then need to be communicated to the rest of the team to enhance collaboration and continuity of care. It is also unrealistic to expect one person to be an expert of all things heart failure and palliative care, and therefore it is important to communicate with the team as needed to recognize when you've hit your knowledge limits and when it's time to call a friend. Finally, the last T is timing. The literature implies that it is never too early to integrate palliative care into the management of heart failure. In fact, it is often done too late. 6 years ago, I would have advocated that a diagnosis of heart failure should come hand in hand with a consult to palliative care. Now, I recognize that might have been overkill and add an impossible burden to the few specialists we have. Remember, palliative care does not always require specialist consultation. In fact, palliative care can and should be delivered by primary healthcare providers. A palliative care specialist is not likely the best person for heart failure disease-specific education, and not necessarily required to review the patient's goals, values, and advanced care plans, which should occur annually. The literature also supports engaging in these discussions and evaluating the need for further palliative care options after the first and every subsequent heart failure-related hospitalization. Now, I'd like to reiterate that this presentation and the tips and tricks were largely curated from a literature review I did back in 2019. As we saw earlier, the updated CCS Heart Failure Pocket Guide now provides more actionable recommendations regarding when to consider palliative care and tips for how to engage in advanced care planning. Their tips align nicely with the when, what, and how of palliative care we've already discussed. This is a photo of my late grandfather. When I told him I was going into nursing, he lovingly and proudly told me I would do wonderfully because there's no better medicine for an old man than a cute nurse. I loved my grampy, and I appreciate the genuine sentiment behind his statement. But aside from it being kind of offensive, he was wrong. We, as nurses, are in a position to do so much more. Now, so far, this presentation has been broad enough to be primarily applicable to all healthcare providers, including nurses. I'd like to shift gears a little and conclude with a brief nursing-specific commentary. Nurses are trusted healthcare providers who cross paths with heart failure patients at various stages of the disease and in a great variety of roles. We are able to build rapport with patients and their families surprisingly quickly. We provide care, support, and information, all while constantly assessing the physical and emotional needs of our patients. We often see people at their worst and in their most vulnerable time of their lives. Thus, we learn things about our patients that might otherwise go unnoticed. Nurses are natural advocates for our patients. We often find ourselves in a position to facilitate bridging the gap between specialists with their blinders on, primary care providers struggling to integrate palliative care into heart failure management, and a patient's own values. As cardiovascular nurses specifically, we are unlikely and ethically unable to avoid involvement in palliative care for patients with heart failure. We have a responsibility to identify our own knowledge gaps, comfort levels, and biases regarding palliative care, and then to seek the education and training required to better support our patients. According to the Canadian Council of Cardiovascular Nurses Standard for Cardiovascular Nursing document, and the position statement on advanced care planning and the role of the cardiovascular nurse, we need to be able to incorporate palliative care interventions as required and to encourage patients to engage in advanced care planning. The cardiovascular nurse is to support their patient in shared decision-making through education, emotional support, and respecting individuality. We are to collaborate with other members of the healthcare team, inform patients of available resources for end-of-life care, and create a safe environment conducive to establishing advanced care plans. While it is not within our role to deliver diagnosis or prognosis, we have a responsibility to implement care plans that correspond with patient values and preferences. We need to engage in these practices and embrace the shared goals of palliative care and heart failure management on a day-to-day basis. thus normalizing our involvement, enhancing our comfort, and ultimately improving a person's experience of living and dying with heart failure. Now back to my grandfather. In many ways, he was the epitome of someone who lived a long and full life with heart failure. He had survived more than his fair share of cardiac emergencies and symptom crisis situations and had eventually exhausted life-prolonging treatment options. But when at age 82, he lay exhausted and frail in a hospital bed a couple months after ICD removal secondary to exposure of a fractured lead, likely caused by a fall, and then further complicated by an incisional infection. "Oh, it's not time for that," was not the appropriate response when palliative care was brought up by family. Nor was, "He's rallied from worse." Within a week of those comments, he received his consult to palliative care, and a couple of days later, surrounded by his wife and a few of his 6 children, he died peacefully. His heart failure had been well managed, but his mortality had not been. There were so many missed opportunities along his heart failure journey to discuss disease trajectory, goals of care, patient values, and advanced care directives. So, train yourself up to be involved in the challenging conversations and to advocate for your patient's needs. Take the time to teach your patient the information they need to participate in informed decision making. Take the time to talk to your patients, to learn what is important to them and what their expectations are, then relay those goals to the team. Whether you meet a person once in an acute care setting during a time of crisis, or you work in a role which facilitates stable long-term relationships, you have the ability to enhance the integration of palliative care with heart failure management. You can improve a person's experience with living and dying with heart failure, and it doesn't even matter how cute you are. Thank you for tuning into this talk, or rather, research soapbox rant, about palliative care and heart failure. I hope it has left you questioning your previous position on palliative care and empowered you to facilitate its incorporation into your everyday practice. If you have any questions, comments, compliments, or concerns, please do not hesitate to email me at the address provided at the beginning.